Welcome back to the deep dive. Today, we're really getting into it. We're grabbing the definitive playbook for the knee Insall Scott's surgical knee and doing, well, probably the most intense anatomical review since our last complex trauma case.
That's the spirit.
Our goal isn't just, rattling off origins and insertions. It's about understanding why every structure matters clinically, surgically. Because in orthopedics, a millimeter, that's huge.
Yeah.
Can be the difference between a win and a revision.
Precisely. You absolutely cannot tackle something as intricate as the knee without knowing the engineering blueprint inside and out.
Yeah.
Down to the micron level, really.
Mm-hmm.
The original authors, Clark, Kransdorf, Conley, Peterson, Scott, they set the standard. They blended gross dissection, cross-sectional imaging, arthroscopy, the whole picture.
Right.
For us, knowing that regional anatomy in detail isn't optional. It's fundamental for diagnosis, for stable reconstructions, for getting predictable results in joint replacements. If you don't know the structure intimately, you're basically flying blind. It's guessing, not operating.
I like that frame. It's like trying to fix a high-performance engine with just a wrench versus having the full CAD drawings laid out.
Exactly.
So let's start with the foundation, the literal hard stuff, bony architecture. But before shape and rotation, we need to talk biology. Bone isn't just inert scaffolding, is it?
Not at all. It's incredibly dynamic. Think about its composition. Dry bone mass is about 70% mineral, calcium and phosphorus locked in that critical 2-to-1 ratio.
Right.
And the other 30%, that's organic matrix, mostly type I collagen. That's what gives bone its tensile strength, stops it from being brittle like chalk.
And the cells living within it keep it adapting. We have the osteoblasts, the construction crew. They lay down osteoid, that collagen protein matrix.
Which then mineralizes. It turns into hydroxyapatite crystals right at that specific boundary, the tide mark zone. You can see it under the scope.
And then the demolition crew, the osteoclasts, those huge multinucleated cells, kind of like macrophages.
They handle the resorption. It's this constant cycle of building up and breaking down, remodeling. That balance is key for bone strength.
And when it tips, like an osteoporosis or maybe stress shielding under an implant.
That's when you risk failure. Insufficiency fractures, things like that. Catastrophic potential.
Okay, so that brings us to the actual structures. Anteriorly, the patella. Largest sesamoid bone, right? Sitting in the femoral trochlea. Its main job seems to be mechanical leverage.
It's the ultimate force amplifier for the quadriceps. Just by lifting the tendon away from the knee's center of rotation, the patella boosts the quad's effective strength of its moment arm by maybe up to 50%. It's a brilliantly simple mechanical solution.
Anatomically, it's that asymmetrical oval shape, makes up the patellofemoral compartment. If we look at the back, the posterior surface, 7 facets. Medial, the larger lateral one, which has that distinct concave shape coronally.
And don't forget the 7th one. Way over medially, the odd facet. We'll come back to that.
And that whole posterior surface is coated in cartilage, thick cartilage.
Up to 6.5 millimeters thick. That is the thickest hyaline cartilage anywhere in the body, which leads to an interesting clinical puzzle.
Right. Because we often see early degenerative changes, chondromalacia, in younger patients, adolescents even, on MRI or scope. But linking those findings directly to their pain, it's surprisingly fuzzy. The correlation isn't always clear.
Yeah, it's a bit of a head-scratcher sometimes.
Yeah.
But the biomechanics explain how the patella handles such incredible forces normally. As the knee bends, going from extension into flexion, the load skyrockets.
We're talking forces like 3 to 7 times body weight in a deep squat, huge numbers.
But here's the clever part. As the load increases, the area of the patella contacting the femur also increases, so that massive force gets spread out, dissipated over a wider surface. It's elegant engineering.
But there's a crucial exception. Every resident needs this burned into their brain, extension against resistance.
Oh yes, the classic gym mistake. If someone's doing heavy leg extensions, especially in that last 30 degrees, that terminal arc of extension,
What happens?
the force across the patellofemoral joint ramps up dramatically, but the contact area actually gets smaller.
So high force, small area.
That's the perfect recipe for aggravating patellofemoral pain. Instant flare-up for many people.
And flipping that, it's why straight leg raises are usually safe. In full extension, the patella hasn't really engaged the trochlea yet.
Exactly. It pretty much eliminates significant force transmission across the joint. Makes it a go-to rehab exercise when someone's symptomatic.
Okay, let's trace the contact points through motion. It's actually a pretty small area contacting at any one time, right? Never more than about 1/3 of the total surface. If you look at figure 1.7 in the book, it shows this well.
Correct. It starts distally near the bottom pole, around 10 to 20 degrees of flexion.
Then maximum contact, like a continuous ellipse, hits around 45 degrees.
And as you go deeper, say 90 degrees, the contact shifts more proximally towards the top of the patella.
Now, back to that odd facet, the clinical tidbit here is its contact pattern.
Right. It only makes contact in extreme flexion, deep squats, kneeling right down.
Activities that aren't maybe typical in daily life for many in Western cultures.
Precisely. So it often stays a non-contact zone. Which is why, if that odd facet does start showing wear and causing pain, some surgeons see it as a strong indicator. It suggests underlying tracking issues or maybe overuse in those deep flexion activities.
That's a great clinical pearl, functional anatomy guiding how we talk to patients. Okay, moving posteriorly. The femoral condyles, the surface the patella glides on, first thing to note, they're not symmetrical?
Not at all. Big difference. The medial condyle is larger, and its curve is more consistent, more symmetrical. The lateral condyle, that's the trickier one. Its radius of curvature increases sharply as you go posterior.
And that asymmetry is fundamental to knee kinematics, isn't it? Especially rollback.
Absolutely. Separating them, you've got the intercondylar notch.
Which is ground zero for ligament attachments. And pathologically, for impingement, the ACL starts as a flat spot high up on the lateral wall. The PCL gets a bigger spot on the medial wall. Figure 1.47 shows this anatomy clearly.
And the size of that notch matters clinically. A narrow notch is statistically linked to a higher risk of non-contact ACL tears.
Not necessarily because the ACL is weaker, but because it gets pinched.
Exactly. It can impinge against the roof of the notch, especially during terminal extension or hyperextension, mechanically jams it.
Which is the whole rationale behind doing a notchplasty during ACL reconstruction.
Precisely. You're carefully sculpting the notch, widening it, creating more space to prevent that impingement on the new graft. It's a purely anatomical fix for a mechanical problem.
Okay, let's talk rotational alignment. The epicondylar axis is key here, especially for TKA. Figure 1.11 highlights this. Runs from the medial epicondylar sulcus to the lateral epicondyle prominence.
That's our reference standard. In a healthy knee, that axis is slightly externally rotated compared to the line across the posterior condyles.
How much rotation are we talking?
On average, about 3.5 degrees in males, maybe a bit less, around 1 degree in females. This slight external rotation is normal, needed for proper patellar tracking and overall kinematics. We aim to replicate this when we set the femoral component rotation in a TKA.
But pathology throws a wrench in the works, like in a valgus knee with significant arthritis.
Oh yeah, the tibia can rotate externally, and that native epicondylar axis can end up externally rotated by as much as 10 degrees relative to the worn posterior condyles.
So if you just cut perpendicular to the posterior condyles in that situation.
Disaster. You'd bake in severe external malrotation of the femoral component. That sets the patient up for pain, instability, patellar tracking nightmares, probably looking at a revision down the line.
It shows how critical understanding that 3D geometry is. Axial alignment is just as vital as varus valgus or flexion extension.
Couldn't agree more. Okay, let's move down to the tibia, the platform, the tibial plateau. Looking at a skeleton, the surfaces seem really mismatched with the femur.
But the minutiae fill that gap in real life, right? They create conformity.
Exactly. But the bone shape itself matters. The medial plateau is much bigger, flatter overall, and has that characteristic squared-off look posteriorly on a lateral X-ray. Figure 1.2 illustrates this.
While the lateral plateau is narrower, almost convex.
And both normally slope backwards about 10 degrees. That posterior inclination is another factor we have to account for in our surgical cuts.
This brings us to a big debate in joint replacement. Gender-specific, or maybe even race-specific, implants. The book mentions the aspect ratio.
Right. That's the medial lateral width divided by the anterior-posterior dimension. And the data shows pretty clearly that women, on average, have smaller aspect ratios than men. Their tibias tend to be relatively narrower side to side for a given front to back length.
And this isn't just in one population, right? It holds across different groups.
Correct. Studies show differences between, say, Japanese females and white females, or in Indian populations. The anatomical dimorphism is definitely there.
So if the anatomy is clearly different, women having relatively narrower tibias, why is there still debate about whether gender-specific TKAs are actually necessary or provide better outcomes?
That's the million-dollar question. Anatomically, yes. Using a standard male-shaped implant on a smaller female tibia can lead to overhang medially or laterally. That overhang can irritate soft tissues, potentially causing pain or limiting function. Proponents argue a better-fitting, narrower implant avoids this.
Makes sense, but does it translate to consistently better long-term results?
That's where the evidence gets murky. The data is mixed. Some studies show benefits, others don't find significant differences in clinical scores compared to well-sized standard implants.
So it might be more about optimal sizing of whatever implant you use.
That's a big part of it. Plus, there are logistical challenges for hospitals stocking multiple implant lines. The dimorphism is real, anatomically speaking, but whether it necessitates a completely separate implant design for every female patient. The jury's still somewhat out on the universal clinical impact. It's that classic tension between perfect anatomical fit and surgical practicality.
Okay, landmarks on the tibia. The tibial spine medial and lateral tubercles, with the groove between them. Important point. These aren't the actual ligament or meniscus attachment sites, right?
Correct. They project up towards the femoral condyles for stability, but the attachments are in the fossa around the tubercles. Laterally, we have Gerdy's tubercle.
About 2-3 centimeter lateral to the tibial tubercles. Crucial insertion point for the IT band.
And quickly, the tibiofibular joint. Need to distinguish the superior joint synovial has a capsule from the inferior connection.
Which is a syndesmosis.
Right, a strong fibrous joint with that robust interosseous ligament. Important distinction when you're evaluating proximal fibula injuries or pain. Hashtag niche and degenerative disease.
Okay, we've laid the bony groundwork. Now let's move inside to the joint surface itself. Articular cartilage, that amazing specialized lubricant. It's mostly water, held in by proteoglycans within a collagen mesh.
And the microanatomy is surprisingly complex. It's not uniform. There are distinct zones based on how the collagen fibers are oriented and how dense the chondrocytes are. If you look at figure 1.13, you can see this layered structure.
Density is highest deep down near the bone and decreases towards the surface.
And that deepest layer, the anchor point, is the calcification zone, marked by that basophilic line we call the tide mark. Now, the big problem with cartilage...
It has basically no blood supply, avascular.
Exactly, which is why it's notoriously bad at healing itself. It gets nutrition by diffusion from the synovial fluid bathing the surface and from the subchondral bone underneath. Damage either source, and the cartilage suffers.
That poor healing capacity leads straight to degeneration chondromalacia. We grade this arthroscopically using the outer bridge classification. That's figure 1.5 in the text.
We need to know these grades cold. It's how we communicate findings in the OR. Grade 0 is normal, healthy cartilage.
Grade of 1 is just softening or maybe some swelling. You can indent it with a probe.
Grade 2, you start seeing small fissures, some surface fibrillation, but usually less than about ½ inch across.
Grade 3 is where it gets more serious. Deeper fissures covering a larger area, often looks like crab meat appearance.
And grade 5, that's full thickness loss. Erosion right down to the subchondral bone. Functionally, that's osteoarthritis. On MRI, these high-grade changes are usually obvious thinning, irregularity.
But those early grades, I and 2, can be tricky on MRI sometimes. Might just show up as some abnormal signal within the cartilage, even if the surface looks okay. We also see chondral flap tears pretty often where a piece delaminates.
Moving a layer deeper, we need to differentiate two key pathologies involving osteochondral fragments, fragments of bone and cartilage. Big difference between osteochondritis dissecans, OCD, and osteonecrosis. Management is totally different.
Let's start with OCD. Typically younger patients, active kids, or adolescents. Classic location is the intercondylar aspect of the medial femoral condyle. What's the key pathology?
The crucial distinction is the state of the bone underneath the fragment. In OCD, the fragment separates from a bed of vascular living subchondral bone. Figure 1.17 shows this concept. The base is alive.
So it has healing potential.
Exactly. On MRI, you might see high signal fluid outlining the separated fragment, but because the underlying bone is viable, if you fix that fragment back in place, it can heal.
Okay, contrast that with osteonecrosis. Tends to affect older adults, usually on the weight-bearing part of the medial femoral condyle. What's the bone like here?
Here, the fragment separates from a bed of a vascular dead bone. See figure 1.20. The blood supply failed, the bone collapsed. Healing is very unlikely.
How does that look on imaging?
Radiographs might show collapse. MRI often reveals the characteristic crescent-shaped low signal line under the fragment, usually with a lot of surrounding bone edema. Figure 1.22 illustrates this. Clinically, especially in older patients after maybe minor trauma, we're increasingly calling this an insufficiency fracture. The bone quality was poor and it just gave way.
Got it. Okay, on to the menisci, the shock absorbers. Crescent-shaped fibrocartilage pads, mostly type I collagen. Figure 1.23 shows their general shape.
Their job is to increase contact area and make the joint more congruent. The collagen structure is key. Look at figure 1.24. It's mainly arranged in a circumferential pattern, like belts in a tire. Perfect for handling compressive loads by converting them into hoop stress.
And there are radial fibers, too.
Yes, those provide rigidity, stop the meniscus from splitting lengthwise under tension.
Functionally, they do a lot. Transmit load, improve stability, spread synovial fluid, prevent tissue impingement. Fairbank's classic work showed what happens when you take them out completely.
Right. Total meniscectomy. It basically guarantees arthritis in that compartment down the road. Fairbank observed rapid degenerative changes. Bone spurs, flattening the femoral condyle, joint space narrowing. You lose that load distribution and the cartilage just gets destroyed.
Which brings us to a major modern concern, something that's really changed our thinking about early OA. The meniscal root tear. Let's look at the medial meniscus first. C-shaped, wider posteriorly, figure 1.26a. It's attached all around the periphery to the capsule and very firmly mid-body by the deep medial ligament part of layer 3, which we'll get to. See figure 1.34.
But the critical attachment is the posterior horn root. It anchors firmly to the back of the tibia, just in front of the PCL insertion. This root is what prevents the meniscus from squishing out of the joint under load.
And tears right at that root attachment. They're now seen as catastrophic, functionally speaking.
Absolutely devastating. Let's break down why. It's all about losing the hoop stress mechanism.
Explain that.
Normally, when you put weight on the knee, the compressive force pushes the meniscus outwards. But because it's anchored at the front and back roots, that outward push gets converted into tension along the circumferential fibers. That's hoop stress. It locks the meniscus in place.
Like the hoops on a barrel.
Exactly. But if you detach one of the roots, particularly the posterior root, you break the hoop. The meniscus can no longer resist that outward force. It extrudes, squirts out from between the bones.
And loses its ability to bear load.
Completely. Biomechanically, the contact pressures on the cartilage become almost identical to what you see after a total meniscectomy. It's a massive hit to the joint.
So functionally, a posterior root tear equals a meniscectomy.
Pretty much. That's the current thinking, and it explains the rapid onset of severe arthritis we often see after these injuries. It's a huge risk factor.
Which is why repairing that root, even though it's technically tricky, is now considered essential whenever possible, trying to restore that hoop function.
Mandatory, really. If you identify a root tear, you have to think of it as a major structural failure needing urgent attention. Okay, lateral side. The lateral meniscus is more O-shaped, almost circular, figure 1.23 again, covers more of the tibial surface.
And its peripheral attachment is different, isn't it? It's interrupted.
Yes, crucially, by the popliteal hiatus. Figure 1.37 shows this gap where the popliteus tendon ducks underneath the LCL to insert on the femur.
So it's not as firmly tethered down as the medial meniscus?
Correct. That hiatus, plus the lack of a strong mid-body attachment to the LCL, gives the lateral meniscus much more mobility. It can move back and forth by up to a centimeter.
And that mobility is protective.
It seems to be. That ability to move, guided partly by the popliteus tendon and the meniscofemoral ligaments, likely allows it to accommodate stress better. Explains why isolated lateral tears are statistically less common than medial tears.
Okay. Associated structures. Connecting the front horns, we have the transverse intermeniscal ligament, figure 1.33, and posteriorly.
Connecting the lateral meniscus posterior horn to the medial femoral condyle, flanking the PCL, are the meniscofemoral ligaments. See figure 1.35.
Ligament of Humphrey and ligament of Risberg.
Right. Humphrey passes anterior to the PCL. Risberg passes posterior. Figure 1.36 clarifies this. Risberg is usually the more substantial and consistent one. They help control meniscal movement during rotation, but their isolated clinical significance is maybe less clear unless it's part of a bigger injury pattern.
All right, let's tackle the core stabilizers inside the joint, the cruciates, ACL and PCL. Highly complex. They're intra-articular inside the joint capsule.
But critically, they're covered by a sleeve of synovium. That makes them technically extrasynovial.
Composition-wise, mostly type I collagen, like other ligaments, but they do more than just mechanical restraint, right? They have nerve endings.
Yes, sensory endings that provide proprioceptive feedback, telling the brain where the knee is in space. It's not just passive ropes. They're part of the control system.
Okay, let's start with the posterior cruciate ligament, the PCL, the strongman. It's close to the knee's center of rotation.
And it's significantly stronger than the ACL, nearly twice the tensile strength. It's the primary restraint against the tibia sliding backwards, provides about 95% of that resistance.
Its function changes with knee flexion.
Definitely. It gets tightest in full flexion. Functionally, we talk about bundles, even though it's really one continuous structure. The main bulk is the anterior part, the anterolateral bundle, which gets tight in flexion.
And the thinner posterior part, posteromedial bundle.
That part tightens more as the knee approaches extension. The PCL also works together with the LCL and the popliteus tendon complex to stabilize that tricky posterolateral corner.
Clinically, PCL tears are less common than ACLs, often from that classic dashboard injury blow to the front of a bent knee.
Or sometimes a severe hyperextension injury. And if PCL deficiency becomes chronic, the outlook isn't great. Untreated chronic instability leads to significant degenerative arthritis, especially in the medial compartment, in something like 90% of cases.
Why medial?
Because when the tibia sags backwards due to the PCL tear, the medial femoral condyle bears excessive load. It grinds down the medial compartment over time.
Makes sense. Okay, now the anterior cruciate ligament, the ACL. The complex check rein against forward movement.
It's the primary static stabilizer preventing the tibia from sliding forward on the femur. Resists up to 86% of that anterior force. Average size is around 38 millimeters long, 11 millimeters wide.
And the modern understanding, crucial for surgery, is based on its two functional bundles. Figure 1.50 shows these.
Exactly. Two distinct bundles with different tensioning patterns. First, the anteromedial AM bundle.
This one tightens as the knee flexes.
Correct. Which is why if you tear just the AM bundle, it will most significantly affect the anterior drawer test, because that test is done at 90 degrees of flexion.
And the other bundle.
The posterolateral PL bundle. This one tightens dramatically as the knee approaches full extension.
So failure of the PL bundle is what makes the Lachman test positive, since that's done closer to extension, around 30 degrees.
Precisely. The PL bundle is also now recognized as being critically important for controlling rotational stability, particularly internal rotation of the tibia.
This anatomy directly explains the evolution and the controversies in ACL reconstruction techniques over the years. The older, standard, single-bundle transtibial technique often fell short, didn't it?
It did, particularly regarding rotational control. The problem was tunnel placement.
How so?
The standard transtibial drilling method often forced the surgeon to place the femoral tunnel too high up, too vertically, on the wall of the intercalator notch.
And that position only recreated the function of which bundle?
Primarily the AM bundle. So
Yeah.
you'd get pretty good control of straight anterior translation. The anterior drawer test might improve significantly.
But the rotation.
But it often failed to restore the function of the PL bundle. The knee remained rotationally unstable. The pivot shift test, which specifically assesses that rotational instability, often remained positive.
So good forward back stability, but still felt unstable with cutting or pivoting movements.
Exactly. That failure is what drove the whole shift towards more anatomic reconstruction. Either optimizing the single bundle placement, putting the femoral tunnel lower and more horizontal to better mimic the PL bundle.
Or moving towards double bundle techniques, trying to reconstruct both bundles separately.
Right. The goal became restoring both AP and rotational stability, based directly on understanding the distinct roles of those two bundles. It's a perfect example of anatomical knowledge driving surgical innovation. #VV, the collaterals and the outer envelope.
Okay, let's move outside the joint now to the peripheral stabilizers, starting medially. This side is complex, famously described by Warren and Marshall back in '79 in their 3 layers. Understanding these layers is non-negotiable for any medial surgery.
Absolutely. It's the roadmap for dissection and soft tissue management. Layer 1 is the most superficial. It's the deep fascia investing the sartorius muscle. You can see this in figure 1.62. The pes-indenting tendons, sartorius, gracilis, semitendinosus, actually run between layer 1 and layer 2. Figure 1.63 shows that plane.
Okay, then layer 2. This is where the main player resides.
The superficial medial collateral ligament, SMCL. This is the undisputed primary restraint against valgus stress, the knee buckling inwards. And it also significantly resists external rotation. It's not just a flat band, it has distinct parts. Figure 1.64 shows the parallel anterior fibers and the more oblique posterior fibers.
And its tension changes through the range of motion.
Dramatically.
Yeah.
Because its femoral attachment isn't a single point, it's more oval-shaped. Look at figure 1.91. The anterior parallel fibers get tightest when the knee is flexed, roughly between 45 and 90 degrees.
While the posterior oblique fibers.
Those are tightest in full extension. This dynamic tensioning allows the SMCL to provide substantial valgus stability throughout the entire arc of motion. It's always got some part engaged.
And if you cut it.
Studies confirm sectioning just the superficial MCL significantly increases both valgus gapping and external rotation. Really highlights its crucial dual role.
Also within layer 2, there's another structure getting a lot of attention lately, especially for patellar stability.
The medial patelloferal ligament, the MPFL. It's really a thickening or condensation within layer 2, running from the medial femoral condyle near the adductor tubercle up to the superior medial edge of the patella.
And its importance seems huge, particularly in preventing dislocations.
It's now recognized as the single most important soft tissue restraint against the patella sliding laterally, especially during the first 20 to 30 degrees of knee flexion. It provides something like 50–60% of the total restraining force in that early range. Massive contribution.
Which explains the common injury pattern we see, right? Avulsion off the femur. Figure 1.65 often shows this.
Exactly. And for patients with recurrent patellar instability, reconstructing the MPFL has become the go-to procedure. You need to restore that static check rein, because the dynamic stabilizers like the VMO just aren't strong enough on their own in that early flexion range.
Okay, layer 3. This is the deep layer, the joint capsule itself.
Right. Deep to the SMCL, you find the deep MCL. These are shorter, more vertical fibers, attaching the meniscus to the femur, meniscofemoral portion, and tibia, meniscotibial or coronary ligament portion. See figure 1.67. Functionally, it's only a weak secondary restraint against valgus stress.
That's a critical point for TKA, isn't it? Knowing you can potentially release parts of layer 3 for balancing without completely destabilizing the knee immediately.
Precisely. Posteromedially, layers 2 and 3 blend together and get heavily reinforced by the complex insertions of the semimembranosus tendon. It has like 5 distinct arms or sheaths attaching back there, including the one that forms the oblique popliteal ligament running up and laterally across the back of the capsule. Figure 1.69 shows this reinforcement.
Okay, swinging over to the lateral side, let's use the C-Better classification here. Layer 1, again, involves fascia lata, the ITB wrapping around, and the biceps femoris tendon. The IT band itself acts kind of like a ligament when the knee is straight.
Then layer 3 is where the main lateral stabilizers live.
Yeah.
The lateral collateral ligament, LCL, and the structures of the posterolateral corner, PLC.
The LCL, that classic cord-like ligament, how does it behave kinematically?
It's pretty simple compared to the MCO. The LCL is tight only in full extension. As soon as the knee starts to bend, even a few degrees, the LCL slackens.
Which is necessary to allow rotation.
Exactly. That relaxation permits the normal tibial rotation that has to occur during flexion and gait.
Now, the lateral side has its own recently rediscovered structure causing a stir, the anterolateral ligament, or AL. See figure 1.71.
Right. Also considered part of layer 3. Its origin on the femur is near, often blended with, the LCL origin, but its insertion is distinct down on the tibia near Gertie's tubercle.
Why all the fuss about this ligament? What's its job?
Its primary role seems to be controlling internal tibial rotation, especially when the knee is flexed beyond about 30–35 degrees.
So relevant in ACL injuries.
Highly relevant. The thinking is, in many significant ACL tears, the AL might be injured too. If it is, the knee can have persistent, profound rotational instability, that high-grade pivot shift, even after a standard ACL reconstruction.
And it gives us a new understanding of the second fracture.
Exactly. That little chip of bone avulsed off the anterolateral tibia. It's now widely believed to be the bony insertion of the AL being pulled off. Finding a second fracture is basically a pathognomonic sign of a significant rotational injury involving the AL, usually alongside an ACL tear.
So if you see a second on the x-ray,
you immediately know the AL is likely torn, and you need to carefully assess rotational stability. You might need to consider specifically addressing the AL, either repairing or reconstructing it, in addition to the ACL, to fully restore stability. Though, admittedly, seeing the AL clearly on routine 1.5 Tesla MRI can still be tough sometimes.
Okay, posteriorly on the lateral side, we have the posterolateral corner complex, PLC, stabilized by the LCL, PCL working with it, and the popliteus muscle tendon unit, along with the arcuate ligament complex. This whole area resists varus stress, external rotation, and posterior tibial translation, especially near extension.
Key components back there include the thick, Y-shaped arcuate ligament, and sometimes a fibellofibular ligament, if a fibella, sesamoid bone in the gastroc, is present.
And finally, the popliteus muscle itself originates in that groove on the lateral femoral condyle, runs down behind the tibia. We mentioned its tendon passes through the hiatus in the lateral meniscus attachment. What's its main job?
Besides helping stabilize the lateral meniscus and resist external rotation, its primary dynamic function is to unlock the knee from full extension.
How does it do that?
In a weight-bearing situation, it initiates flexion by internally rotating the tibia on the femur or externally rotating the femur on the fixed tibia. It's the little muscle that starts the whole flexion movement. The ignition key for bending the knee. Hashtag tag, 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 Vertex sticks, neurovasculature, and synovial spaces. The supply lines.
Okay, we've built the structural framework and wrapped it in stabilizing layers. Now the logistics, the supply lines, and internal environment. Let's start with the synovium.
Right, the synovium. It's that thin membrane lining the inside of the joint capsule.
Yep.
Figure 1.38 shows its extent. Made of synovicytes, type 1 are like macrophages, cleaning things up. Type 2 are synthetic, producing hyaluronic acid and other components of the synovial fluid.
And crucially, it wraps around the cruciate ligaments.
Making them extrasynovial, yes. It also extends upwards into the suprapatellar pouch, above the patella. It's the largest synovial recess in the knee. Figure 1.40 shows that pouch.
Sometimes inside the joint, we find these folds or remnants called plicae. Figure 1.41.
Yes, leftover bits from embryonic development when the joint cavity was forming. The medial patellar plica is the most common one to become clinically relevant.
How so?
It can get thickened, inflamed, and snap or rub against the medial femoral condyle during motion, causing pain. Sometimes requires arthroscopic resection if it's really symptomatic and conservative treatment fails.
We also have bursae everywhere around the knee, little fluid-filled sacs to reduce friction.
Absolutely. Clinically important ones include the prepatellar bursa, housemate's knee, the intrapatellar bursae, clergyman's knee, and the pes anserine bursa on the medial side.
And the one in the back, Baker's cyst.
The popliteal bursa, yes, often called a Baker's cyst. It's important because in about half the population, it actually communicates directly with the main joint cavity through a one-way valve mechanism. See figure 1.43.
Which explains why you often see a large Baker's cyst when there's significant swelling inside the joint from arthritis or a meniscus tear. The fluid gets pumped back there.
Exactly. Now, innervation. The knee gets a rich nerve supply from two main groups. Posteriorly, branches from the tibial and obturator nerves. Anteriorly, from the femoral, common peroneal, and saphenous nerves.
What about the ligaments and menisci themselves? Do they have nerves?
It's a bit controversial, especially for the main body of the structures. Some evidence suggests nerve fibers only penetrate the very outer periphery, maybe the outer third of the meninge. But the surrounding tissues, the capsule, the synovium, are absolutely packed with nerve endings, both pain receptors, nociceptors, and position sensors, mechanoreceptors.
And that sensory input has direct clinical effects, like the reflex quad inhibition.
Yes, that's a huge one in rehab. And effusion, swelling inside the joint, greater than about 60 millirel, triggers neural feedback that essentially shuts down the quadriceps muscle. Makes it incredibly hard for patients to activate their quad after injury or surgery until that swelling is controlled. Aggressive swelling management early on is key.
We also need to be mindful of nerve vulnerability during surgery or trauma.
Absolutely. The common peroneal nerve is the classic example. It runs right around the fibular neck, very superficial. Highly susceptible to injury from direct blows, varus, stress, or even surgical dissection on the lateral side. Got to treat that area with extreme respect.
Okay, blood supply. It's a rich network and anastomosis, mainly fed by the genicular arteries branching off the popliteal artery in the back. How do the cruciates get their supply deep inside?
Primarily from the middle genicular artery. It branches off the popliteal, pierces the posterior capsule near the oblique popliteal ligament, and supplies the bulk of both the ACL and PCL. Figure 1.85 shows its path.
And a key point for the ACL, it doesn't get much blood supply from where it attaches to bone, does it?
Essentially none. Its viability depends almost entirely on that middle genicular artery supply within the ligament substance. That's why proximal ACL tears often bleed so much into the joint, and why complete tears rarely heal on their own. The blood supply is just too compromised.
What about the menisci? Where's their blood coming from?
It's notoriously limited. Only the outer periphery, maybe the outer 10–30%, gets a decent blood supply from branches of the superior and inferior genicular arteries. This is the so-called red zone. Figure 1.86 illustrates this vascular pattern.
And the inner part, the white zone.
Avascular. Gets nutrition only by diffusion from synovial fluid. This vascular zoning is critical for treatment decisions. Tears in the outer vascular red zone have healing potential, making them candidates for repair. Tears in the inner avascular white zone generally won't heal and often require partial meniscectomy.
Patellar blood supply.
Comes from that anterior anastomotic ring formed by the geniculars, the descending genicular, and the recurrent anterior tibial artery. Figure 1.87 shows the network. Nutrient arteries, according to Scapinelli's work, mainly enter the patella through the distal pole and anterior surface, figure 1.88. Compromising that inferior pole supply during surgery risks a vascular necrosis of the patella. Lastly, surgical incisions and skin blood supply. This is critical knowledge. The skin flaps rely on a plexus of vessels in the fascia, just superficial to the deep muscle fascia.
And there's a bias in where that supply comes from.
Yes, a significant medial bias. The main arterial inflow to the anterior knee skin comes predominantly from medial vessels, especially the saphenous branch of the descending genicular artery.
So, when planning surgery, especially a revision where there are multiple old scars?
The general rule is to use the most lateral of the previous longitudinal incisions. Why? Because the skin flap based medially, relying on that stronger medial blood supply, is generally more robust. Using the lateral incision helps preserve the blood supply to the medial flap, reducing the risk of skin edge necrosis or wound healing problems. It's about keeping that tissue alive.
Okay, we've covered the static parts. Now, how does it all move together? The knee isn't a simple hinge. It has 6 degrees of freedom, 3 translations, 3 rotations, all happening on those non-matching bone surfaces.
It's the ligaments and soft tissues orchestrating the motion. The classic passive movement that locks the knee straight is the screw-home mechanism. See figure 1.89.
That's the internal rotation of the femur on the tibia in terminal extension.
Right, or external rotation of the tibia if the foot is free. It brings the joint into its most stable, close-packed position.
And our understanding of how the condyles actually move during flexion has changed quite a bit with newer dynamic imaging, hasn't it?
Massively. The old teaching was that both condyles rolled backwards equally on the tibia. Fluoroscopy, dynamic MRI. They show something different.
What's the current view?
It turns out the medial femoral condyle is relatively static. It pivots more than it rolls. The significant posterior rollback happens almost exclusively on the lateral side. The lateral femoral condyle rolls back much further than the medial one.
Wow, so it's less like a symmetrical hinge and more like one side pivots while the other rolls?
Exactly. Kind of like a J-curve motion, but primarily on the lateral side. Knowing the medial side is more of a stable pivot point is hugely important for implant design in TKA.
How so?
You want an implant that allows for or even encourages that natural asymmetric motion, pivoting medially, rolling laterally. Trying to force both sides to roll back equally, like some older designs did, actually violates the knee's natural kinematics and can lead to instability or weird, paradoxical movements.
Let's tie the ligaments back into this motion. The MCL, with its broad attachment, provides stability throughout.
Yes. Because of that oval femoral origin, different parts tighten at different times. As we said, anterior fibers tighten in flexion, posterior fibers tighten in extension. Figures 1.90 and 1.91 show this. This ensures continuous valgus stability across the whole range.
The LCL is simpler.
Taught only in full extension, that immediately slackens in flexion to allow that crucial rotation.
And the cruciates, managing AP and rotation.
Right. The ACL primarily checks anterior translation and also resists internal rotation. The PCL checks posterior translation. Remember the bundles, ACL's AM bundle tightens in flexion, PL bundle tightens near extension. Figure 1.5. It's this complex interplay of tension and relaxation in all the ligaments that allows controlled motion.
Finally, muscle actions. We mentioned the popliteus unlocking the knee. What about the big ones?
The popliteus initiates flexion by externally rotating the femur on the loaded pubia. Critical starting move.
Quadriceps. We think of them as extenders.
But arguably their most important job during normal walking is eccentric contraction. They control knee flexion during the early stance phase, acting as brakes to absorb shock and decelerate the body.
And the hamstrings and pes anserine group.
Primarily knee flexors, obviously. But they also act like important dynamic guy ropes, stabilizing the knee and pelvis medially and posteriorly. While they contribute some rotation, especially internal rotation from the pes group, their main role is probably more sagittal plane control and pelvic stabilization rather than being primary rotators.
Well, this deep dive into the Insall and Scott blueprint definitely reinforces that the knee is an incredible piece of biological engineering. Tight by collagen anchors, levers, shock absorbers, intricate controls. It's amazing. And these anatomical details we've covered aren't just academic. They have direct, massive impact on diagnosis and surgery.
Absolutely. Reflecting on our chat, I think one of the biggest functional shifts in understanding recently is that equivalence between a medial meniscus posterior root tear and a total meniscectomy. Realizing that losing hoop stress is so catastrophic makes prompt root repair non-negotiable for joint preservation now. Huge implications.
I was also really struck by the ACL bundle discussion. The idea that for years, standard techniques might have been missing the crucial rotational control aspect of PL bundle's job simply because of tunnel positioning. That's a powerful reminder of why we constantly need to refine our understanding of anatomy and its surgical application.
Couldn't agree more. And the MPFL emerging as the dominant restraint against lateral patellar tracking and early flexion, providing over half the force, that completely dictates how we approach chronic instability. It's the primary static structure to address.
So for surgeons, it's about constant integration, planning TKA rotation based strictly on the epicondylar axis, especially knowing how much it can vary in arthritic valgus knees, recognizing a second fracture as a sign of likely ALL injury and significant rotational instability.
And managing soft tissues during TKA. Knowing the deep MCL in layer 3 is only a secondary valgus restraint allows for more precise, calculated releases to balance the joint without causing gross instability. Every layer, every structure has its specific role and limitations we have to respect.
So we've dissected the blueprints. From the patella's leverage to the medial condyle's surprising role as a pivot, we'll leave you, our listeners, with a final thought to consider. Given this intricate network of static stabilizers, especially the AL's role in controlling internal rotation and the ACL's PL bundle resisting rotation near extension, what specific dynamic, perhaps multiplanar exercises should be part of a rehab program to specifically train the knee's rotational stability, moving beyond just simple front-to-back control? How do we translate this detailed anatomy into better functional recovery?
Some to chew on. Keep digging into these blueprints, integrate them into your thinking and practice. We'll catch you on the next deep dive.